some of my talk has already been covered by the earlier speakers, and it's quite short. So, as we've seen in the previous talks, that management of fungal keratitis is indeed challenging frequently because the fungi, unlike bacteria, they penetrate the resonance tissue and the endothelium and can present with advanced keratitis. We do not have a wide variety of drugs to use for fungal keratitis, and also many of these drugs have very low concentration in the anterior chamber, like unless you debride and you use natamycin frequently, we do not have great penetration in the aqueous humor. And also prolonged use can cause a lot of surface toxicity, and we do see a lot of resistant fungi, and ultimately these are patients who need surgical intervention. So it was thought that in patients who have deep keratitis in which the fungi cannot penetrate, maybe a medication which can act at the site of the infection, cases of deep keratitis, or in patients who have a thick hypopion or a lot of endothelial exudates. This may give us better results. So we just go over a few reports of literature and find an answer as to whether these injections actually have a role in our practice or not. So, looking at a few in vitro studies, we begin with amphotericin B. There was a study which evaluated the concentration of amphotericin B, which was achieved in the aqueous humor of rabbits, and 3 modes of injection were used: intrastromal, intracameral, and topical. They realized that after the intrastromal injection, they achieved very good levels of the drug in the cornea, and the aqueous humor, and this was maintained until 7 days. However, the intracameral use also gave very good levels of the drug in the aqueous humor, but it remained only for a day. And when the topical amphotericin was used, if frequent debridement was done, then only then they could achieve a good level in the aqueous humor. Once voriconazole became popular, we had some studies about voriconazole also. As we know, it has a much better penetration into the aqueous humor, and the penetration after topical use of voriconazole is extremely good, and it exceeds that achieved by oral therapy of voriconazole. And it also helps us to, by avoiding use of oral voriconazole, to avoid the systemic side effects. However, what was observed in rabbit eyes was that within 22 minutes, it had a half-life of 22 minutes in the aqueous humor and around 2.5 hours in the vitreous. So, it means that if we have to achieve good levels in the aqueous humor, you have to give voriconazole very frequently, like maybe half-hourly. Then there was another study which evaluated the susceptibility profiles of various antifungal agents to the common fungal organisms that we see, and they reported that voriconazole had a very good susceptibility to all the organisms which they had evaluated in their study, including filamentous fungi and yeast. Next came ketoconazole with 82%, amphotericin B 76%, and followed by itraconazole and fluconazole. In fact, what they have reported is that the MIC90 levels which were required for voriconazole were lowest for Candida species and they were highest for Fusarium species. So if we try to look at the literature for the use of intracameral amphotericin B, we see that these reports are much earlier when voriconazole was not available, and most of these are very short case reports. And just summarize them in this slide. The use of this modality of treatment has been reported in patients who have hypopion and deep fungal keratitis, which does not respond to topical treatment of at least 10 to 15 days. They have been used for both filamentous fungi and yeast. Amongst all the reports, the sample size ranges between 2 to 12 patients. The doses are also very variable, 5 to 25 micrograms per 0.1 ml. And the number of injections that have been reported ranges from 1 to 13. Most of the reports suggest that there has been good response to the treatment. However, all of them have continued additional treatment like topical natamycin or some form of oral therapy with fluconazole or ketoconazole. They have reported cataract formation. However, it is not clear whether the cataract was because of the inflammation that is present in any case in these infected patients, or it is a result of the injection. But one thing that we all know is amphotericin does produce a lot of significant anterior chamber inflammation, and hence very often after giving the injection, it's very confusing, and one cannot decide whether the severity and the increase that you're seeing in the inflammation is a part of the keratitis, which is worsening, or it is because of the amphotericin. And hence many of us are very apprehensive about using amphotericin in routine practice. After the advent of voriconazole, also we have a few case reports on the use of intracameral voriconazole. Again, these have been used in patients who had deep keratitis not responding to topical treatment, mainly reported for the use for filamentous fungi. Sample size ranges between 2 to 10 eyes. Dose is quite standardized, 50 micrograms per 0.1 ml, and the number of injections that have been used is between 2 to 8. However, when most of these patients had been taken to the operation theatres, and the endo-exudates were also clean, along with, the AC wash was given, and then the injections were injected. This is one patient who underwent therapeutic PK for fungal keratitis. After 4 days, the patient has a hypopion and some endo-exudates, which you can see superiorly. And after 3 intracameral voriconazole injections, the patient showed a very good response. Sorry, that was intracameral voriconazole. Then there are some reports on the use of intrastomal voriconazole also. One of these studies this has the highest number of cases. It reports 12 patients who were smear and culture positive for fungal keratitis, and they were non-responsive to topical natamycin and systemic azoles. All the patients were given 1 or more intrastomal injections of voriconazole. Of the 12 eyes, 10 eyes had healed with scar formation, and the other 2 patients showed a perforation. So this is one case where a patient presented, it was a 30-year-old female who presented with worsening fungal keratitis. The patient was put on topical natamycin and oral azoles. The patient underwent a couple of injections and showed some response to intrastromal voriconazole. The topical and the oral treatment was continued, and after another 2 injections, the patient showed a very good resolution. Now, with the availability of Vozole PF from Orolab, we do not really need to dilute the original voriconazole, which we had to use 20 ml, and a long process of dilution. Vozole PF is very handy, and it can be reconstituted with just 1 ml, and you can use 0.1 ml of from that. This is another patient who was a 19-year-old patient, was being treated with antibiotics, and the patient presented with worsening fungal keratitis, did not respond to topical natamycin. The patient underwent intrastromal voriconazole injection after a couple of weeks, and after around 3 injections, the patient showed a very good response. However, in this patient, topical voriconazole also started. This is another patient who underwent therapeutic PK for fungal keratitis. The patient showed a recurrence after 5 days, and I do not have the patient follow-up images, but the patient had a couple of injections of intracameral and intrastromal voriconazole given. However, the patient worsened and had to be taken for a regraft. So what we learned from the literature is that for all these modalities is that the case series are small, and voriconazole of course is recently more popular, and the results are a bit confounding because the other treatments have been continued simultaneously, and things like AC wash have also been done. So there was it was very much needed that we had a randomized control trial which would give us some answers to the utility of this modality of management. So there was a recent report from AIMS which compared the efficacy of topical voriconazole and natamycin, and it compared it with intrastromal voriconazole and topical natamycin in patients who had recalcitrant fungal keratitis. They included 40 eyes in the study, and the patients were randomized to either receive topical voriconazole along with topical natamycin, or topical natamycin along with intrastromal voriconazole. What they noted is that the patients in the group which was treated with topical voriconazole showed good response to treatment, and they had better visual outcomes. 19 of the 20 eyes showed a good resolution in the topical voriconazole group, whereas 16 of the 20 eyes showed a good resolution in the intrastromal voriconazole group. So this, they concluded by saying that topical voriconazole seems to be a very useful adjunct to natamycin in the management of fungal keratitis, and intrastomal injections, at least in their study, did not offer any additional benefit over topical therapy. So I would like to summarize by saying that intracameral and intrastomal antifungals, recently, especially voriconazole, do have a limited role in selected cases. However, exact frequency of the injection and the dosage needs to be determined. One needs to look for signs of toxicity. And after all this, also the management of deep and extensive fungal ulcers still remains a challenge. Thank you.